So for everyone on the call, we're really excited about the opportunity to share with you this information. My name is Dr. David Hicks. I'm the Deputy Health Officer of the Jefferson County Department of Health. And we have Bryn Manzella also that's on the call from the Health Department. And it's going to give you some basic background, and then we're kind of move on, is we understand that particularly in communities of color, we need to make sure the correct and accurate information is presented so that your constituents, your friends, your family members can make informed choices for themselves, particularly related to this COVID-19 pandemic, the vaccine, testing, whatever it is. And our aim is not to tell people to get vaccinated. What we want to do is provide the information and get active feedback from you to let us know what we need to do to provide that information. Just for some housekeeping, I have everybody on mute so we can minimize background noise. Also, this is being recorded. And so others that may not be able to participate on this call, they will be able to get this link to play back. I'm asking if everybody can hold all their questions as much as possible to the very end after our guest speaker presents. And we want to give ample enough time for question and answer session, but we want to give you this critical information right now. I will be sharing my screen. Dr. Kennedy will be sharing her screen to show you some PowerPoint presentation and imaging, and we're gonna proceed from there. So let me just start by, I'm going to share my screen and I'm going to talk about this just high level overview of the vaccination allocation plan that we're in Alabama as right now. And so as you can see here, in Jefferson County, we're currently in a phase where we are doing everybody in what we call Group 1A. That's our frontline healthcare workers. These are people that work in settings where they're interacting with patients. They're at high risk of getting COVID-19. Also, all of our first responders, that's law enforcement, that's our firefighters, paramedics, and then persons that are age 75 and older. That's what we're currently in. And the link that you have on your screen shows you where you can go to see where we're going moving forward. Soon, once we get through this phase, we'll be talking about teachers and people that work in grocery stores and those essential workers, but we're not there yet because we have limited doses of vaccine available. But we are aggressively trying to get through that. Now, here in our county, and this is just for Jefferson County, we set up a call center, we set up a website to be able to for people to quote unquote pre-register. So let's just tell you, if you and your family members and friends and constituents have internet access, that is the best way. If you go to jeffcoema.org, and that's 24/7, that's available. There's a green link button. I'll kind of show you what it looks like in a second. You can pre-register. If you have any questions during weekdays, you have any questions about if you're eligible or not, then you can call the phone number that as you see there. That's 858-2221. But the best way, if you can, is online, because the phone lines potentially could be tied up. This is what that website looks like. So when you go into that Jeffco EMA site, this is what you'll see. And then there's that green button that says Vaccine Info Registration Form. And all you have to do is click on that button. And when you click on that, you put in some information, basic information. How do you contact? How many doses do you need? And you'll automatically be put on the list. The last thing I'll just say is what we're currently doing is when people are on that list, the health department is using that list to push out messages, either a phone call or it's an email. And we are saying first come, first serve. The health department has appointments available. Now, we're not the only players in the market that's offering vaccines. So hospitals are offering vaccines for their patients that are 75 and older that's in their health systems. There's going to be pharmacies there's community health centers. There's more and more that are coming online as we speak. So the health department is one of several entities, and we're just trying to make sure that we have enough coverage to fill in the map so people have access. On MLK Day, we vaccinated 1,500 people at the health department at 2 different locations, one in Birmingham and one in Gardendale. We're going to start doing more of those things at different locations throughout the county. So that's kind of my introduction of where we're at. And certainly at the end, we can entertain any questions about the allocation and the vaccine rollout. But right now, I'm going to introduce our keynote speaker, presenter, Dr. Kirsten Kennedy, who is the Chief of Hospital Medicine at the University of Alabama at Birmingham. She is an expert and on the front lines of taking care of people that have COVID-19. And we're just privileged to have her to share her perspective and educate all of us about the COVID-19 vaccine and anything else. And again, please hold your questions for the end. And I will ask again that people can keep their phones on mute. And then Dr. Kennedy will be here to answer all of your questions. And I'll be, just in case there's something I need to cover from the health department's perspective. So with that, Dr. Kennedy, I'll give you the floor.
Thank you. Thank you all for coming, especially at the end of a long day. I'll try to make this a good use of your time. I'm excited to be able to bring this information to you. I think it's important for me as someone who has an understanding of COVID and also of the vaccines to be a good steward of that information and share it broadly. But then also for you as community leaders to be able to take this information, digest it, and also be able to share where you feel appropriate. So again, we'll want to keep questions till the end if possible, but as you think of questions, feel free to put them in the chat. If you're like me, I will forget if I don't get it out immediately. And then we'll go through the chat at the end and I'll make sure that we answer all of your questions. If you'll give me just a second, I'm going to share my screen and I'll get us started. All right, so again, this is just an informational session about the COVID-19 vaccine. I want to start by saying that I have no disclosures. I'll give you a little bit of a roadmap of what to expect here. The plan here is to briefly review the impact of COVID-19 here in the US. And then we'll spend some time talking about in general how vaccines work, and then give you a brief overview of the 2 vaccines that are available to us currently. And then we'll leave the rest of the time to answer your questions as you put them in the chat or as you sort of speak them out at the end. So what do we know about COVID-19? So first of all, we know that infection with the SARS-CoV-2 virus, that's the virus that causes the illness that we know of as COVID-19, can really result in a broad range of illnesses, from people with very mild cold-like symptoms to those that develop end organ failure, respiratory failure, and even death. I think what's scariest about COVID to me is that we don't know how it's going to affect each person. I mean, we know that anyone that is already in a poor state of health because of, severe medical conditions that are pre-existing, or those that are older than 65 and maybe have less reserve are more likely to get sick, but that's actually not consistent either. We did this earlier today, and I was telling that group that I recently admitted a 96-year-old woman to the hospital whose only symptoms was that she had had a nagging cough for a few days, and she had fallen and felt by herself. And she ended up being COVID positive. So again, there's just not an easy way to know for sure how someone is going to fare if they get this infection. So what impact has it had here in the US? I updated these numbers as of this morning. We have seen over 24 million confirmed cases of COVID here in the US. And we have also, unfortunately, seen over 400,000 deaths due to COVID. And I will tell you, we started working on these slides last week, and the data that we had was from last Thursday on the 14th. And at that time, the number of deaths was 387,000. So that's almost 15,000 deaths in just 1 week, which I think is already sobering, but I think it's even more sobering if we look at it and give it a little perspective by looking at some other causes of death. So in 2017, the leading causes of death in the US were number 1, heart disease, and then number 2, cancer at just under 600,000 deaths. And if you look at where we are with COVID-19 deaths and the rate at which people are dying from this, we could very easily surpass at least the second leading cause of death if we don't do something about it. I think the other important thing for us to note is that lots of people are getting hospitalized because of this, and the mass hospitalizations all at once, they're placing an unprecedented strain on the healthcare system. We have not had to deal with this in the past, and that has been really our drive behind wanting to flatten the curve or decrease the amount of people that get this illness, so that those that do get sick and have to come into the hospital can really get good care and adequate attention. So let's talk about vaccines. What is a vaccine? So the formal definition is that a vaccine is a biological product that's used to safely induce an immune response to give you protection against an infection in the event that you were to ever come in contact with that infection in real life. So in short, a vaccine is a safe way to educate your immune system, to train your body to be able to protect you from an infection without you ever having to actually have the infection itself. Now, these COVID-19 vaccines that we have are called mRNA vaccines. Why is that exciting? Because this is the first mRNA vaccine to receive broad authorization for use in humans. Now, there are a couple things that I want to point out to you that I think are important myths to bust right out of the gate based on my conversations with patients. So number one, this is not the first mRNA vaccine ever developed. You will sometimes hear that. There have been prior mRNA vaccines developed. There was work around Zika, the Zika virus, and that was an mRNA vaccine. There have also been other viruses where they have done initial studies using mRNA, including the rabies vaccine. So this is not the very first one. And I will also point out to you that this mRNA technology is not new. This technology dates all the way back to the late 1980s. The other thing that I would point out for you is that this is not the first mRNA vaccine to be studied in humans. You will sometimes hear that. There's actually an ongoing study of the Zika vaccine in humans that started, I believe, in 2019. And so the COVID vaccine is the first one to get approval from the FDA to be used broadly, but it's not the first time that a human has ever gotten an mRNA vaccine or that it's ever been studied in a human. In fact, I think once they finish the Zika studies, that will probably be the second mRNA vaccine that will be authorized for use in humans. So we should back up a little bit and let's talk about what mRNA is, because we hear the term a lot, but we very rarely hear really any definition for what it is. So mRNA stands for messenger RNA. So what is that? Essentially, DNA, which is in the nucleus of our cells, is the blueprint for what we should look like, for what every cell in our body should look like. The DNA never leaves the nucleus, though. So if the DNA wants to be able to express what it wants your cell to look like, it has to have a messenger to do that because it can't leave its home in the nucleus. And so that's where mRNA comes from. So that is RNA that is sent out from the nucleus to the cytoplasm with a message, essentially. And a ribosome, if you think about it, is like a transcriptionist. It transcribes whatever the message says and creates that protein, okay? You will hear people say, oh, this mRNA vaccine, it'll get into your DNA and change your genetic makeup. It can't do that. mRNA, by definition, does not reside in the nucleus. It does not touch the DNA. It always stays on the outside, and its purpose is simple. It provides the message, and then it is destroyed, okay? So the technology behind this is actually really cool when you understand that. So essentially what we've done is we've created a vaccine that includes mRNA, so the message, to tell your cells how to make this harmless piece of the COVID virus. So there's a protein on the outside of the SARS-CoV-2 virus that is called the M-spike protein. That protein in and of itself is harmless. Now that protein in conjunction with the virus is very important. It's essentially the crowbar that the virus uses to get into your cells. It's the key. It's how it opens your cell to get into the cell and start to infect it. Without the crowbar, there's no way for it to get inside, okay? Now, if I give you just the protein, that's harmless. It can't do anything. It's like if I gave you a steering wheel, you can't drive anywhere with that. The steering wheel has to be attached to the car for you to get anywhere. So what they've done is they've identified a protein that's on the surface of the cell that in and of itself is harmless, but that is very important to the virus's ability to spread. And so your body will read this message from the messenger RNA to make this protein. And once it reads the message, it breaks down the mRNA. Then it will take the protein that it just made based on that message, and it's going to put it on the outside of one of your cells. Now, when your immune system sees that, when your infection fighting cells see this protein sitting on the outside of that cell, it's going to freak out. What is this doing here? This protein is not one of us. I've never seen this protein before. And so it's going to start to kill that protein. It's going to break it down. But as it does that, and this is very important, it produces antibodies to it. So that if you ever see that protein again, it's going to have antibodies already in stock, ready to go to fight it off if it comes again. So again, going back to the definition of the vaccine, what this does is it teaches your body how to identify the SARS-CoV-2 virus without you ever actually having to have the virus in your body. Now, again, it's only giving you the message to make that one protein that by itself is completely harmless. It does not give you actual virus. So this mRNA vaccine does not contain any of the live virus and cannot give you COVID. And the other thing that I want to continue to stress, because there's been a lot of this misinformation on the internet and on social media especially, is that mRNA does not affect or interact with your DNA in any way, shape, form, or fashion. Now, this is just sort of a schematic to show what we just talked about. So if you look here, this is the DNA of the virus. And this is the sequence within the DNA that codes for that M spike protein. So what they have done is they have synthetically copied that sequence to create mRNA that creates the protein. This is the message. They then package that in a lipid nanoparticle because they know from research back in the 1990s that if you try to inject just the mRNA without some sort of protective coating, it gets broken down too quickly before the cells can even get to it. And so if you think about this, is kind of like if you've ever heard of enteric coated aspirin, it tries to protect the aspirin to get through your stomach so it doesn't cause as much issues for you. It's kind of the same thing. It's like a protective coating to allow it to get to its destination before it gets broken down. So that is what is injected in the vaccine. With that protective coating in place, it's able to make it into the cell to provide the message. Your ribosome will transcribe it and make that little M spike protein that sits on the outside of the SARS-CoV-2 virus. And then when your body sees that, it will create an immune response and an immune response in response to having seen it. Now, things that I think are really important to point out is that the COVID-19 vaccines, even though they were produced quickly, and we can talk about that, they're still being held to the exact same safety standards as any other vaccine. Before any vaccine can be authorized, the FDA has to very carefully review all of the safety data from the clinical trials. Also, the Advisory Committee for Immunization Practices is responsible for reviewing all of the safety data before they can provide a recommendation for it to even go up for authorization. And then after authorization, the FDA and the CDC continue to monitor vaccine safety and monitor for side effects. So this doesn't end just because in December they authorized it for use. There is still a governing body that is continuing to monitor whether or not people are tolerating the vaccine well. So let's start by talking about the Pfizer vaccine, because that's the first one that got approved. So if you would like to read it, I told the group this morning, if you have insomnia and need something to put you to sleep, you can find the entire document here. You're welcome to read it, but I am going to give you the quick and dirty so that you don't have to torture yourself with that, right? So this is a really busy slide, but here are the things that are important for you to know. Number one, the Pfizer vaccine is given 21 days. The doses are given 21 days apart. It's 2 doses, give or take 4 days, right? So you can doesn't have to be perfect right at 21. For the study, we're doing active surveillance for 6 months after getting the dose, right? And that active surveillance included visits either via telemedicine or in person with nasal swab. And they were checking to see if those people developed COVID-19 symptoms or if they developed any sort of side effects from the vaccine. And the second thing that I want to point out to you is that they're still monitoring those folks. Their safety monitoring plan is to continue to monitor people for 2 years after the second dose. So we are actively looking to see if there are going to be any long-term side effects potentially from this. So the Pfizer vaccine is about 30 micrograms. I think that equates to 0.5 mLs, half a milliliter, that is administered into the arm 21 days apart, 2 doses. Again, it's an mRNA vaccine, and their goal for this study was 44,000 participants. Now, I will point out to you the study did not include pregnant patients and it did not include pediatric patients. So the data that we're looking at is only going to apply for people 16 and older. And I will also note that it's an ongoing study. Just like we said, they're still monitoring those folks. It was randomized and placebo controlled. And so for those that don't do research, that sounds nebulous, but essentially what that's saying is that this was a very strong study. They took extra measures to make sure that there was no way to infuse bias into the results. So it was randomized, meaning that they couldn't cherry pick the really healthy people to give the vaccine to, right? So they could say that everyone did really well with it. It was randomly selected who got the vaccine versus who got the placebo. And then by having a group that got the vaccine to compare against those that didn't, you could really get a good picture of whether or not the vaccine was truly doing anything, if it was really effective. And so they enrolled in total 37,796 patients. Now, only 37,088 patients completed both doses. That is not a reflection of the study necessarily. That's very common in research. People will sign up for a study. They might do part of it and then they kind of get lost to follow up. They don't answer the phone or life gets busy and they miss an appointment. And so those people get removed from the study. So of those that followed through, there were 37,088. Half of those people got the vaccine and half of those people got placebo. They were completely randomized. The patients didn't know which one they were receiving, and the person given the injection didn't know what they were injecting. They didn't know if they were getting vaccine or placebo. That's another way to make sure that you can take all the bias out of it. And what they found was that of those that got the actual vaccine, only 8 of them developed a COVID-19 infection, as opposed to 162 of those that got the placebo. And that calculates out to about 95% effectiveness. So this graph is another way of looking at it. If you look at this, the red is the placebo group and the blue is the group that got the actual vaccine. And if you look on this axis, this is the cumulative incidence of COVID-19 infections. And along the bottom here is the days after the dose. And if you look for the first kind of 7 to 10 days, they look exactly the same. Everybody's the same. And then at about the 14-day mark, they split. And that's where we know people start to produce, they've had antibody production at that point. And you can see those people that got placebo, the number of folks that got COVID just continued to increase, as opposed to those that got the actual vaccine, they stayed pretty steady. We didn't see those people getting the virus. Now, the most common adverse reactions that they saw were injection site reaction, so pain or redness at the site of the injection, fatigue and just feeling really exhausted, headache, muscle pain, joint pain, fever, and chills. I will tell you that all of these reactions were considered self-limited, which means that they went away on their own and they were short-term. Now, I will point out to you that there have been some cases of allergic reactions to those people that have gotten the Pfizer vaccine. So this is after it got approved and they started rolling it out. It's important to put it into context though. So 21 out of the 1.8 million doses that were put out resulted in a case of anaphylaxis, so a severe allergic reaction. Now, of those 21 cases, 17 of those people had a documented history of allergies or allergic reactions. So they had had allergic reactions to medications before. This was not something brand new or specific to the COVID vaccine. And of the 21 cases, they were able to follow up 20 of them for all available data, and all of those people had recovered. That other person, again, it's with any other study. Sometimes people get lost to follow up. You can't get in touch with them, so you don't know what happened. But we do know that there have not been any deaths. That being said, even though this is a very small portion, and this is in line with the amount of allergic reactions that we see with other vaccines, we have still, out of an abundance of caution, made the decision that whenever someone is vaccinated, we will monitor them for at least 15 minutes to make sure that they remain safe. And any site where we are administering the vaccine, we make sure that we have medical staff and medical treatments on hand to deal with any potential complications. That said, remember, we didn't include pregnant patients in the study, so this data doesn't apply. We can't say that pregnant people will respond the same way, but at the same time, we know that pregnant patients are at higher risk of having a really bad outcome if they were to get the infection. So the guidance currently is that each patient should have shared decision-making conversations with their doctor to decide if, based on their history and their body, if it's appropriate for them to get the vaccine or not. And there's some guidance available both for pregnant women and for those that are breastfeeding that are considering whether or not to get the vaccine, available on the CDC site, and we can make that link available. So in summary, the Pfizer vaccine was highly effective, 95% effectiveness at preventing cases of COVID-19 in those that received it. And the side effects were pretty mild, right? So just local site reactions, and then fatigue, low-grade fever, achiness, sort of flu-like symptoms that the participants described as mostly mild to moderate. So now we'll talk about Moderna. That's the other vaccine. Again, if you want to read it, we can make sure that this link is available to you, but I'm going to walk you through the salient points. So the Moderna vaccine is given in a dose of 100 micrograms, administered in the arm 28 days apart, give or take a few days. It too is an mRNA vaccine, and they sought out to have 30,400 participants. That, for those who don't do research, I will tell you that is a very good number. That is a well-powered, strong study to have that many patients participate. This study excluded pregnant patients as well, and it also excluded those under the age of 18. So for Pfizer, it was 16 and below that were excluded, and for Moderna, it was 18 and below. This is a busy slide again, but the most important thing to note is that they too are monitoring patients for 2 years after that second dose. So this is not a, we've given you the vaccine and now we're done with you. They are continuing to monitor to make sure that this is safe. Now, that 30,418 patients enrolled, 27,898 saw it all the way through with both doses. Half of that group got the actual vaccine, half of that group got the placebo. And what they found was that of the group that got the vaccine, only 5 people developed a COVID-19 infection, whereas 90 people in the placebo group ultimately developed or contracted COVID-19. That calculates out to a 94.5% effectiveness, so very similar to Pfizer. And this is a similar graph. The blue this time is the placebo. The red this time is the vaccine group, but same thing. This is the cumulative incidence of people developing COVID, and this is the time from getting the dose. And again, for the first 10 days or so, they are exactly the same. Those groups are perfectly identical. And then at the point where the body would have developed a critical amount of antibodies, enough to have an impact, you start to see it split, and you start to see that those that got the placebo have a higher incidence of contracting COVID-19 as compared to those that got the vaccine. Again, the side effect profile is very similar to Pfizer. Injection site pain, and then those flu-like symptoms that we discussed. Also for these, they noted that they were self-limited and that they were mild. And so that's a summary for the Moderna vaccine. Highly effective, very similar to Pfizer, with a similar side effect profile, with self-limited short-term side effects similar to flu-like symptoms and pain, and sometimes pain and redness at the site of the injection. Now, there are some important facts that I think we need to talk about related to the vaccines. Number one, the vaccines will not give you the COVID-19 infection. None of the COVID-19 vaccines that are in use currently or that are under development actually contain any of the live virus. It only contains, for the mRNA vaccines, it only contains the message to tell your body how to make that that protein that in and of itself is harmless. People can experience some normal side effects like fever after getting a vaccine, but that's actually a sign that your body is building immunity. So most people for the first dose felt nothing, right? Because your body had never seen it before, didn't initially have a major reaction to it, but after that second dose, your body has seen that protein before, and your body knows that that protein should not be there. And so your body mounts a response as though you got an infection, as though you were just infected. And so that's why you see the fever and you have some of the chills and the achiness. That makes a ton of sense. When you think about the way that you kill bacteria or viruses, a common way to do that is to raise the temperature, right? If you think about for babies, if you want to sterilize the nipples and the bottles, what do? You boil them, right? You raise the temperature. And so that's what the body is trying to do. The body thinks that you may have been infected. It sees this foreign protein, and so it raises the temperature in an effort to try to kill it off. That is normal, and it's a sign that you're mounting a good immune response. That said, it takes time to mount a response. It's not an instantaneous thing. Your body has to have days to be able to build up that stock of antibodies. And so you can still get infected with the COVID-19 virus, either at the point of vaccination or right after vaccination and get sick because your body doesn't have the defenses in place yet. So that's why it's really important, even around the time of getting the vaccine, that you continue to be vigilant about wearing your mask and social distancing and good hand hygiene. Other facts: the mRNA vaccines will not cause you to test positive on the COVID-19 viral test. Now, I want to clarify that a little bit. Most of the tests that we use to test for active infection, like current infection, is checking to see if you have the actual virus in your system. Because these vaccines do not contain any part of the virus, you're not going to test positive on those. Now, some people will get antibody tests, okay, and that's usually a sign of whether or not you've had a previous infection. And if you've gotten the vaccine, you would show up as positive on an antibody test. But that is just saying that your body has antibodies to COVID, which we know you should have if you got the vaccine and your body made antibodies in response to getting the vaccine. So that's normal. That doesn't mean that somehow the vaccine gave you COVID-19. Again, plenty of rich information, both about coronavirus in and of itself, and then also about the vaccine if you'd like to do more research on your own. But while I'm here, I'd like to make myself available to answer questions for you, either based on the presentation or if you have other questions about things that we didn't bother to cover here. And I will look, I don't see anything in the chat, but feel free to just unmute yourself and ask questions.
This is Dr. Hicks. Dr. Kennedy, that was phenomenal overview. And again, if anyone needs to unmute themselves, we can throw out the question, put stuff in the chat, and I'll be monitoring the questions. You know, I'm curious to see a couple of things I'm thinking about is what information beyond what Dr. Kennedy presented do you think would be valuable? What other information do you want to know? What things may have been confusing that has been put out, you know, for the past several months? And another thing I think to think about towards the end, you know, is what's the best way that you think it would be to communicate to your constituents or your family members this type of information so that we can make sure everybody's informed? So I'm just throwing it out there, but this is open forum, so please, someone jump in.
So I have a question. My name is Jason Meadows. My question is, I've heard mixed answers to this, so I just hoping to get a little clarity. I've heard from a personal health leader who's a manager of one of the medical facilities in Birmingham that the vaccine has been proven to last for 4 months. But then I was on another panel and somebody asked that question, and that healthcare official would not answer that question. And so I just wanted to know if there's any firm information surrounding how long is the vaccine good for?
Yes, so there has been some preliminary data out that shows that at this point, people appear to have immunity for at least 8 months after getting the vaccine. Now, remember, because they just did this trial in the summer, they're continuing to monitor those patients. So you're only going to know as long as we have, like, as much time has gone by. So between July to now, basically. What they're doing, though, is they're monitoring antibody levels in those participants, and they're watching to see how the antibody levels decrease. Now, that's normal. You have antibody levels decrease over time if you're not ever exposed to the infection. If you think about it, that's why you have to get a tetanus booster. Like tetanus, that vaccine lasts for a really long time, but eventually you have to get a booster because you will start to see your levels decrease. So they're monitoring those patients to see at what rate the antibodies decrease. And right now, from what they're seeing, they believe that it lasts at least 8 months. Now, we've got to wait more time to see, with each month, what their levels look like, and that's going to inform that. So that's probably why that person was uncomfortable answering that question, because it's still something that they're studying. I will throw out there, I said this on the call earlier today, I'm hopeful that it's going to be at least a year, and that this would be kind of like the flu vaccine. We have to get the flu vaccine every year. I think that would be ideal, and I think that's where the data is pointing, but I can't know for sure until we get the data back.
And Dr. Kennedy, I want to add on top of something you just said to what Mr. Meadows just asked, is if you naturally get the infection, the antibodies that you're developing with natural infection may go away as soon as 6 weeks. It could be 3 to 4 months. So right now, what Dr. Kennedy is saying is from the vaccine, we're talking about antibodies still being in your body for at least 7, 8 months, as opposed to 4 months. So already the vaccine is proven to be better than naturally getting the infection.
Right. And that actually leads to another thought. One of the questions that we got on the call earlier today was whether or not someone who has had the COVID-19 infection can or should get vaccinated. And the answer to that is yes, you can be reinfected with COVID. And that is because those antibody levels decrease. And we know that they, like Dr. Hicks said, they don't stay around much longer than 3 to 4 months. And so if you've had COVID-19, it's perfectly safe to still get the vaccine. And in fact, the studies included patients that had had previous confirmed infections, and those folks did fine. They had the same outcomes as those that had never been exposed.
Oh, Dr. Kennedy.
Yes.
Hi.
Hi, this is Janice Williams with Jefferson County Senior Services. I had a question. I've had seniors to ask, what's the difference between the vaccines where one has to be refrigerated and the other one doesn't?
Yes. So
why is that?
So they both have to be frozen. Pfizer has to be kept at a much lower temperature. And actually it's because of the lipid nanoparticles. That's really an excellent question, by the way. So the two companies use different lipids to coat their mRNA. And so it just so happens that the ones that Pfizer uses require, I think it's like -70-degree temperatures before it's reconstituted and drawn up into the syringe. And Moderna's, it just so happens that the lipids that they use still have to be kept cold, but they don't have to be that cold. So that's the difference.
Saying that this is something to kill Black people, but when I see a Black doctor, as I've seen others on TV, I'm like, now this just doesn't make sense. Why would these doctors accept the vaccine and they're out to kill Black people? They're Black, so
yeah. Well, I mean, we don't
just
use the vaccine to kill Black people. The virus is killing Black people.
That's true. That's true.
Like I tell people, when people get sick with the vaccine and they come to the hospital and they can't breathe, they're not asking me, well, what do you know about remdesivir? I can tell you, we know a lot less about remdesivir, the treatment that we're using in the hospital, than we do about mRNA vaccines. We don't have 30 some odd years of research behind some of the treatments that we're giving people when they get COVID. We are figuring it out as we go and doing the best that we can. And so I really, that was part of my decision-making process too, is like, if I've got to choose between the two, the one that actually has the most data behind it is the vaccine. It is built on, years and years of research that people have done. And so people, I mean, people have to put that into perspective, you know?
So, Doctor, this is Commissioner Tyson, and thank you, pastors, for coming on this call. I wasn't on the one at 11, and I actually was wondering. They have been doing research on this virus for that long, even though the virus hadn't came out.
No, so they've been doing research on how to use mRNA for that long. But I think the other thing that I'll point out to you, and this is important for people to note when they look at the timeline and how quickly they were able to develop this vaccine, is that number one, coronavirus in and of itself is not new. Okay, we know old school coronavirus. Old coronavirus is what causes the common cold. So this is why they call it the novel coronavirus, because this is a new variant of it. So if you think about it, you know, the other thing that I've explained to people is they revamp the flu vaccine every year. They do it in less than a year. How do they do that? Because they already know a lot about the flu vaccine. So if you have a virus that you already know a lot about, you have a head start. And you can look at the timeline. They were able to sequence the DNA of the SARS-CoV-2 virus by January. They had the sequence. And once they had the sequence, they knew how to make the mRNA. They were able to use that sequence to pull out the part that makes the protein and code it to start working on developing the vaccine. There were a lot of things that were available to them because of our past knowledge, both related to coronavirus, and also pay attention to the name of that virus, SARS-CoV-2. You've heard SARS before. They were working on trying to create a SARS vaccine back when that virus was rampant. That died down because SARS died down, right? We didn't need it anymore. But there was a lot of information that was already there that they were able to use as a foundation to create this vaccine. And so when you think about it, creating a vaccine to a disease that you already have some knowledge about and doing it in a year, it's not that unheard of. They do it with the flu every single year now. But so I'm tired of hearing about the Tuskegee experiment, but at the same time, I'm thankful to hear it because I think it's the start of a good conversation.
Yeah, a couple of things I want to just say, and I see this in the chat. You know, we absolutely recognize that hearing and seeing someone who looks like you, talks like you, from where you're from, is critically important, and someone that you can certainly trust. So you're right. Earlier comments about it's all about who the messenger is, and we recognize that. And you're going to be messengers, right? In your own right. You know, regarding the Tuskegee, study. I mean, it's something that in med school we all learn. I mean, and in public health school I learned. And my wife's from Macon County, Alabama. She grew up in Tuskegee, right? So yeah, it is real, and we can't dismiss it. And Tuskegee syphilis study is one of multiple violations of people's dignity.
That's right.
That the medical community has perpetuated. And so you have the medical experimentation, then you have structural racism, institutional racism.
Yep.
And you add all that together, and as Dr. Kennedy was saying, that there's no doubt of why people have mistrust in systems, governmental systems and institutions, and even the health department. It was the United States Public Health Service who conducted the Tuskegee syphilis study in the state of Alabama.
Mm-hmm.
Okay, so we can't be naive to think just because we put a smiley face on and ask you to do something or consider something, you're just going to take that. We have to own the sins of the past and recognize it, say it for what it is, and then figure out, well, how can we as a group collectively move beyond that and try to rebuild trust. But it can't be on the terms of the institution. It has to be in terms of the community who was violated in the first place.
That's right.
And so that's why getting the feedback from you all and everyone else is vitally important. You should be in the driver's seat to say, this is the information we need. This is how we want it to be presented to us. This is the pace we want to go at, is what has to happen. and then you hold us accountable to that. One of the other things I just want to mention, a really good comment I got as a direct message to me, but I think it's good for the whole group, is so one of the issues is, all right, so say we achieve our goal to get all this information out. We make sure everybody has the knowledge. Now everybody's now at that point where they say, I think I'm going to make this decision to get vaccinated. Is there going to be enough vaccine available to get them vaccinated? Right? So this is and this is good. So and the follow to that is, then what's the timeline? When is this all going to take place?
Yeah.
All right. So you all have seen these reports where Alabama is, if not the worst, the third worst or slowest at getting vaccine rolled out. Okay. Reasons for that, I don't need to get all the details of it, but that's the reality. And one of the concerns is, if we don't vaccinate fast enough, could Alabama be punished by not getting vaccine? Will the government say, oh, I'll give this other state vaccine because they're being really good at getting the vaccine now? So absolutely, there's a sense of urgency. In our county, we have 43,000 residents that are 75 years of age and older. How quick can you get those people vaccinated before you can think about moving beyond? Mm-hmm. We have people that are 65 and older saying, I'm ready to get it. Y'all are holding me up because you're talking about 75 and older, right? So what the wonderful thing, at least in Jefferson County, I would say, is we have a lot of partnerships where the health department alone is not bearing the burden. UAB is not bearing the burden alone. So all the hospitals, all the clinics, all the doctor's offices, all the pharmacies, all of us together have to have this all hands on deck. And so we're pushing ourselves. I know the hospitals are pushing themselves. But we need to do more. I will tell you, I was just on the phone with the state. I have regular calls with them about what's going on throughout the state of Alabama. All of us in public health are saying we need more doses. Load us up. We'll get the job done one way or the other. So we're trying to get loaded up, and we want to have more vaccine clinics, more appointments available. The hospitals are saying the same thing. They said, load us up. We want to make sure we take care of all of our folks as well. Mm-hmm. So everyone's asking for the more doses. So if we get more doses being pushed, if the new administration in office is able to push out the goal is to get 100 million Americans vaccinated in 100 days, we're gonna get if we get those resources, we got to get ready. So I think that ideally 3 weeks from now, hopefully, that's my prayer, 3 to 4 weeks, we have vaccinated enough of our 75 and older population that we can move and add other groups in, because our teachers are waiting. Our grocery store workers are waiting. We talked about that before. So I'm hoping 3 to 4 weeks and we start opening it up more, because when we get to essential workers, there's so many people in that category.
Yeah.
And I will tell you that for essential workers, there's a disproportionate number of African Americans that work in essential work jobs. Okay. And so I think that's where the bulk of people of color are going to get vaccinated, quite honestly. A lot of the ones that are higher risk, when you get to the essential worker category, there's gonna be others. And I will tell you, that was thought through when they were thinking about the orders of why did one group go first versus the other. They look into the proportions of workers was in a certain racial group or other groups, or if you lived in rural parts of America. They took that into account of why they have the orders they are. Now, we don't tell that story good, but that's built into the order. So when people say, let's get rid of the order and just so anybody come get a vaccine and let people jump the line, that's going to make disparities worse, because it was designed to get the highest risk people in the right spot in the line. And we have not been able to express that probably effectively to people, but there's a logic to the order, and people that, just like your risk of getting exposed, dying is included. So high risk medical conditions. We know that we talk about frontline healthcare workers, but there's a huge amount of healthcare workers. They might not be the highest paid healthcare workers, but a huge amount of healthcare workers are underrepresented minorities.
Yeah.
Okay, so built into the order, we should be able to get the right people vaccinated as quick as we can. But it's a challenge. This is the greatest vaccination effort in the history of the world.
But, you know, there are people that get COVID and, you know, they have a brief respiratory illness, a flu-like illness, and it's over. But we also at UAB have developed this COVID long-term clinic where we're following people that continue to have these neurologic symptoms related to COVID, that continue to have ongoing lung problems, you know, people that are developing myocarditis after having had COVID and have developed heart failure. I mean, it is really, really significant, the blood clots that people develop after having had COVID. And so I think your point is really important. And I think that we should probably in future presentations make sure that we show that, because as I told people, you know, I can't think, as I think through the science behind the way the mRNA works, the fact that it is short-lived and that it's designed to be destroyed after it sends the message, I have a hard time thinking of what the long-term side effects could be related to that. But I know what some of the long-term side effects to COVID are, and I know I don't want those. So, you know, that's important to weigh out.
All right. I think everybody should see on the screen that website link to do the pre-registration. Remember, that is the fastest way to get on the list if you have internet access, but you still have the EMA's call center that you see there. This is really important to just get the word out. And that'll be that. All right. Thank you so much, everyone. Like I said, we've recorded this and we will be certain to get this information out. Thank you again, Dr. Kennedy, and everyone have a good night.
Absolutely. Good night, everybody.
Thank you. Good night.
Thank you.